Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today I'm joined by Amy Gibbar, Chestnut's VP of Integrated Care, who's been with Chestnut for over 28, count them, 28 years. Amy's expertise, her secret sauce, if you will, is identifying and overcoming barriers to care, building teams that provide a continuum of co-located and integrated mental health, substance use, primary care, and housing services for mentally disadvantaged populations. Amy, thanks for joining me. How are you?
I'm well. How are you?
I'm doing well, thank you. I'm
Good.
doing well. So, 28 years, and for 23 plus of them, if I have my math right, you were clinical director and then moved over to your current role. What prompted the switch?
So a little over 5 years ago, Chestnut really wanted to realign our services regionally so that we could, I think, do a better job at integrating our care. And so that means integrating primary care, mental health, substance use, prevention. So really focusing on the individual and really trying to get that whole person care better integrated.
So, the question of the day, what does a VP of Integrated Care for Chestnut do?
I feel like my main job is really to solve problems. And so whether that's a community issue, whether that's a particular patient issue, a staff issue, it really is about listening to what the problem, what the need is, and then looking at whatever resources Chestnut has. And if Chestnut can't meet that need, then maybe other resources outside of Chestnut to solve whatever the problem at hand is.
I see. You ever seen Pulp Fiction?
I have.
So you are the wolf. You are Chestnut's the wolf. You solve problems.
I never thought of it that way.
You are renowned far and wide for solving problems, as you mentioned, particularly the barriers of access to care and pulling together teams to solve these problems. What special talent does it take to do this? Special talent, is it something you learn over 23 plus years? Is it something, for instance, you acquire? Is it something you're born with? Is it a combination of the two?
Well, I mean, first and foremost, I think it's gifts from God, but I won't go into that any deeper. But I really think that I had an early mentor who really taught me about being people smart, and that's what she called it. What I've learned about being people smart is it's really about knowing the people that work for you, what their strengths are, what their needs are, so that you're able to use all the resources that are available to you. And so not only do you need to be people smart about your staff, but you also have to be people smart about the folks who you're trying to help in the community. And so really trying to embrace their strengths and then using those strengths to help solve whatever their needs are.
That doesn't sound like something. You may have some of those intuitive skills. You may have the built-in EQ, if you will, but I think those things, having people smarts, comes over time. Now, those things become, I think, acquired where you have them as sort of a sixth sense.
I also think it comes down to I think I'm known for being very forthright. And so if you can't handle constructive criticism, if you can't handle someone telling you where I think you really need to go from where you are, then you probably don't want to work for me or get services from us, because I really do believe that by being forthright, you create that trust between everyone. And I believe that conflict can be healthy. And so we're not always all going to agree on everything. But I think if we are as transparent as possible with each other, you create that trust factor that then enables you to lean on and use the people smarts. So whatever it is that people bring to the table, if they know what you think they have that is a resource, then I think they're willing to give it back to you at any given point if you're forthright.
Yeah. It's really interesting. Just as an aside, for the last couple of weeks, we've had contractors in here redoing our kitchen. and they're for the most part Spanish speaking. And I'm in my office and I hear them in the background. Sometimes they're arguing. And of course, I don't speak the language. I can only pick up little bits and pieces, but it always just struck me that it was constructive arguing. They were looking to solve problems. And every so often I'd go in and check it out. And it was done in a certain, it maybe is a bit of an oxymoron, but it was sort of civil disagreement. And I'd also hear them laugh. It was really kind of an interesting dynamic. And I agree, sometimes and oftentimes conflict is good so long as at the end of the day or during it, you're all looking to get to a common goal. I like to discuss several techniques or processes that you've implemented that have facilitated greater access to care. For instance, how did you revamp the intake process for residential care?
So what we were finding, there were a couple of things that we thought were standing in the way of good access to residential care. One of those had to do with timing. And so I believe that when you are reaching out for help, you're ready for help in that moment. And so it could be that if we get back with you tomorrow or the day after tomorrow, you might not think you need help because you might just feel better because time has lapsed. Or it could be that there's other barriers in the way that next day, like transportation or childcare or other things. And so I really believe that if you can give people help in the moment when they're asking for help, you're much more likely for them to accept that help. And so we had to think of a way where we could take as many people as possible on the day that they were asking for help. And so that was one issue to solve. Another issue to solve is that the people coming to us generally have comorbid issues that you need to screen for and be aware of when you're taking individuals. And so we know that people who are struggling with behavioral health issues tend to also have more complicated medical issues because when we're struggling with behavioral health issues, we're generally not taking care of our physical health either. And so because of that, it requires us to really carefully screen for primary care issues and make sure that we can address those and we're well aware what people need on that side of the business. So what we started doing was having folks, and before they came into residential, their first stop is actually our primary care folks. And so those primary care folks can then screen, assess, and make recommendations for the physical health of those individuals. And then from there, then they can move into our residential then to treat the behavioral health issues that they're struggling with. And so by doing that, it really is putting those issues in the hands of our providers, so our nurse practitioners and our physicians who can do the best assessments of the physical health needs and tell us whether those needs can be met while they are in our residential treatment. Whereas typically when folks go into residential treatment, you have a gatekeeper that may be a case manager or an RN or someone that is making sort of an educated decision about whether can we handle that seizure disorder or can we handle that person that is insulin dependent. And so the people doing it aren't quite as qualified. And you can set up protocols, to do it as safe as possible. But I truly believe that when you have the experts at that front gate making those decisions, they can best tell us how we can help that individual manage those medical conditions so that we can then focus on the behavioral health conditions when they come to us.
I want to come back to some of these processes and techniques, but I also wanted to ask you, because I know you're an advocate for whole person care. Is what you're describing that bringing all these elements together and looking at all of these issues as one continuum?
It's definitely looking at the whole person because when they're able to get their physical needs met first, that then enables us to then look at the mental health and then any substance use risks or activity, and then have a plan that focuses on all of those elements for the individual. But we truly believe that without looking at the primary health care of someone, you're probably not going to get very far with the behavioral health because people want to feel good. And so if you're just treating part of that individual, they're still not going to feel good. And so while you may be helping them with that substance use recovery, let's say in the moment, if they have, something aching on their body, it's going to be really hard for them to stay the course in their recovery journey if you're not also looking at whatever the physical health needs are.
Yes. So back to these processes and techniques that you've implemented to lower barriers to access to care. You recently implemented a hot handoff process. What is that all about?
So what we were finding with our residential treatment is we had more open women's beds than any of our other beds. So our male beds were staying full and our crisis residential beds were staying full, but the beds for our women were not staying full. We had over half of capacity to take folks. And when I looked back at the data and why people weren't coming in, it had to do with us calling people back the next day or the following day. And like I referred to earlier, people then had other barriers, other things that came into play because it was a day or two later when you were getting back with someone. And so what I told my staff is we need to prioritize the women. We need to see that if we can give what's called a hot handoff, meaning the woman is on the phone, she's called, she's talked to central access, given her information. I want you to be able to say, I am now going to transfer this call to someone at the residential unit who will be able to take more information and schedule a time for you to come in today. And so it wasn't put in voicemail. We didn't take the person's number. We actually handed that call to an intake person that could get that person scheduled for that same day to come in. And so by doing that, the last month, we were able to take in 44 people on the same day that they called for help, which I think is pretty incredible.
Yeah, for sure. What would you say was maybe your one or two thorniest challenges, ones that took particular creativity or persistence to overcome? I mean, you've been talking about structurally and generally some of the things that you've needed to implement to lower these barriers. Anything perhaps recently or over the last handful of years you've been doing this that leaps to mind that required a lot of creativity and persistence?
So, I mean, I can think of one recently when in the last 5 years, we've really focused on developing services on the Missouri side versus the Illinois side of business. And there are certain sort of philosophies that drive what I do. And I'm not willing to bend on those philosophies. And so there was an occasion where we were working with a community partner and we had a difference of opinion on peer staff and who you should be able to hire and who you shouldn't. And so the discussion came down that in our agreement with them, they were going to define what peers we could hire and what peers we couldn't. And we had multiple meetings to discuss it, and they weren't willing to bend, and I wasn't willing to bend. Because to me, when you're a peer staff, it's about what you're doing to stay in recovery, not necessarily how long you've been in recovery. I think there are people who, are taking care of themselves and been clean and sober for a couple months, and they're doing everything they need to stay in recovery. Yet there are people who maybe they haven't had a drink in 3 years, but they're not taking care of themselves. And so my point to this partner was, to me, it's all about what the person is doing to take care of themselves than how long they've actually been in recovery. And so because we couldn't get beyond that definition, we had to move on to another community partner to accomplish what we wanted to accomplish.
Yeah, interesting. You mentioned these philosophies that sort of underpin your work. What would you say are the one or two non-negotiable philosophies?
I would say the recovery philosophy is definitely something that's non-negotiable. I think to be in this business, you need to believe that everyone can recover. And so whether it's from a substance use, a mental health, or a combination of both, or even when you're talking about primary care, you have to believe that people can get better, and that if they have the supports in place to help guide that, then you can see people improve. I also think that I talked about sort of the recovery part, but what goes right along with that is being trauma informed. So I think we all have to come to this work and understand that people come to us because of what's happened to them. And so we always need to address folks, whether it's our staff or our patients and clients, thinking in the back of our mind, what could have happened to this person to have brought them to this place? And I think if you come with that philosophy, then you're much more likely to treat people with the respect and dignity that they deserve.
Yeah, yeah, excellent. With all that's going on in Washington, what do you envision being the biggest challenges in the coming months, coming years?
So I think right now what we're struggling with is just the speed of change. I love change. And so, for people to work for me, that's my first question to them is, how do you deal with change? Because I'm always changing things up. I always think we can do things better. And so if change isn't for you, then, this probably isn't the right position for you. Saying that, I think we're seeing change so quickly right now, though, coming from the federal government. Have been multiple executive orders come down that we have to look at. We have to decide how that might have to change what we're doing or what processes we have in place or what policies we have in place. And so I think right now it's just trying to keep up with the change and legally those things that we have to change in order to stay in business and continue to get the funding that we're getting.
Yeah. Last question. We referred to your problem-solving abilities. You referred to your problem-solving abilities. Everybody I've spoke to at Chestnut before this conversation refers to you as a brilliant problem solver. What advice would you give to people generally, not just for the work that you do at Chestnut and your colleagues do? What advice would you say? How would you boil down the essential elements to being a good problem solver?
So when I go in to solve a problem, I already have in my mind sort of what I think might solve it. But then I think you have to seek input from the people that are going to help you solve that problem. And so I always go to, I have 11 people that report to me. I always pull them together as a team and say, here's our next opportunity. Tell me how you think we can solve this problem, or what do you think we can develop to help with this? And so I always listen to their feedback. I might not agree with all of it, but I listen to it. We all listen to it as a group, and then we discuss that feedback and sort of come to a conclusion of what the best solution is. The other thing I think you have to be willing to do is when you make a mistake, you have to own up to it immediately as quickly as possible and change course. And so, there's times where we'll come together and maybe we tried our first plan. And I'm like, okay, we're on to plan B. And what I always tell my folks is you can't just have a plan A and B. You have to have a plan A, a B, a C, a D, and the list can go on and on and on because you have to be willing to take new information, and that's usually new data, new input from your patients and your clients, input from your staff. You have to be able to take all of that and continually try to change and make things better. Things do not stay the same in this business, and you have to be willing to make that continual change.
What have you gotten better at?
I guess probably being invested more in my staff. So I historically was someone that really focused on the patient client as number one. And so I came into this business always thinking, what would I want my mother to receive? What would I want my child to receive? So I think it's important that when we're in this business, we think of who is it that's the most important to us and what would we want them to receive? How would we want them to get this treatment? And so I've always been really good at that. But I've gotten better at taking staff and their pain points into consideration. So not just thinking about what's best for the client and patient, but doing that in conjunction with how does that balance with what staff needs are. Staff come to us with their own trauma. Staff come to us with their own needs, their own strengths. And so how do you balance that? And so I think over time, I've gotten much better at balancing both of those.
Has there been, getting back actually, I just wanted to ask some general thoughts about getting very good at problem solving in your work. Obviously, your work, I guess is one way to put it, is herding cats sometimes, anytime you have to get teams together and various stakeholders across the community and so on and so forth, it becomes a challenge. Is there one particular impediment that you come across time and again in doing this?
I think keeping in mind the difference in generations, and I've been with Chestnut 28 years. And so I would say prior to 10 years ago, I would say it was easy to define what drove people to work, what drove people to have a mission-driven job. I would say about 10 years ago, that started changing. So how I look at it now is I really have two sets of staff with very different needs. And so trying to come up with policies and processes that still work well for our patients and clients, but balance the needs of those two different sets of staff. I think the younger generation, they just don't have the same, I would say, loyalty as previous generations. And maybe that's not the exact word, but if they can find a reason to leave a place of employment now, and they will do it. And so whereas I would say prior to that, building those relationships with your staff really kept folks with you. And now it's bigger than that. You really have to work on how you're addressing staff. You have to address them maybe a little differently. You have to find ways to empower them more. You have to find ways to keep them satisfied in a different way than you did before. Prior to, I would say 10 years ago, I really felt like people came to Chestnut because they believed in what we did and they believed in who we served. And now I think it's much more complicated than that. I think people are looking for more than just the meaning. They're looking for things beyond that. And so how do you balance that with previous generations that really were just here to help people? I think it's more complicated than that now.
So what are one of those two things that motivate them beyond meaning in their work?
I think we see people now that really want to feel appreciated for what they're doing in different ways than before. So I feel like prior, people had more intrinsic satisfaction, and that was enough. I think now, because I'm going to blame it on social media, but I think people want to feel good on extrinsically also, not just intrinsically. And so you have to find ways to really show others how people are doing well. Whereas before, that might not have been is important to people. And it could be just because we didn't have as many ways to do it. You might have had a bulletin board in a hallway that people walked by. And now people are on their phones, they're on their computers. And so finding ways to show staff continually how you appreciate them and letting others know that, I think, is much more important to staff now. And so I'm willing to do that because I have the best staff that work for me. And so it's just finding those ways and keeping up with it, because it's a continual struggle to work with showing your appreciation, because people at Chestnut, they give their all. They put a lot into their job. So how do I, as a manager, continually show what they're doing and the great things that they're doing for our patients and clients?
Yeah, no, it's fascinating. I hear that from business leaders, all industries. So clearly that is very much a thing. Any final thoughts, Amy, on your work, on any projects you're working on that you want to give us a little bit of a sneak preview about?
We did just start a new grant. It's a Redeploy Juvenile Justice Grant. And so this is an evidence-based approach to keep kids out of the corrections department. And so kids are given a second chance instead of being incarcerated to get their lives back on track. And so I'm really excited for my staff to get that program up and running. It's been operating in the state for many years, but Chestnut was given the opportunity to take over the program from another agency. And so I'm very excited about that opportunity. Just one more thing I thought of, sometimes when we're in the social service fields, people want to focus on sort of just social service rhetoric. And I think it's really important that those of us in management look for resources outside of social services. And so I think if you read things that come more from the business arena or more from the philosophy arena, it can really help you be a better manager in social services. Because yes, our number one job here is to help people, but we also have to keep our doors open, which means we have to balance our budgets and we have to have good processes in place. And so I just think we need to have a broader approach to how we do this work and not just focus on social service philosophies.
Yeah, that is a very important point because I see that all the time in this space where people are very, perhaps it's not the best way of putting it, but blinkered. They don't bring some of those other practices and those other disciplines into the work, particularly in this moment where I think people are looking at these kind of services with different eyes. They want to see a return on some of these programs, on the money that's going toward them. And that is also a very interesting recurring theme in all these conversations I have, is I know that most of the Chestnut people are very aware of that. They're aware of that implicitly and explicitly, implicitly to the extent that there's this understanding, and not just an understanding. What they do is bring all these stakeholders, law enforcement, small businesses in. And I don't think you could do that if you were not communicating that as a central ethos to your work.
I agree. Yeah. And I think, when you can use business model, like I'll just give you an example. Patrick Lencioni, who I think has a great approach of, he's very Christian based, but then he's also very business oriented and he works with all kinds of businesses. But he does something called, one of his books where he talks about the lightning round, which he has a book called Death by Meetings. And so his whole point is don't kill people with your meetings kind of approach. But he talks about something called a lightning round. And so I meet with my direct reports every week. And that's how we start every Monday off, is with a lightning round where we simply talk about a few things that we have to get done outside of what's in our schedule. And then the other thing that I instituted about, 15 years ago or so, is people have to have a personal goal also. Because what I found is that if we're each not taking care of ourselves, we can't then take care of the folks that we need to at work. And so by incorporating sort of those business things that you have to get done that aren't in your schedule and those personal things that you need to do to keep yourself well, you're going to be better at home and you're going to be better at work. And so I think strategies like that can really help with that balance.
Well stated as far as death by meetings. If that in fact is the case, I am at least mathematically 80% dead. Anyway, Amy, I really appreciate this. I was looking forward to the conversation because in a way, this is really where the sausage gets made. This is how it all gets put together. Obviously, it's important, the work that ensues from this, but it's, all about putting these teams together and making sure the teams are composed with the right people, et cetera. So I'm really glad we had this conversation. Thanks so much for taking the time, Amy.
Thank you, Charles.
Today I spoke with Amy Gibbar, Chestnut's VP of Integrated Care. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.